Okay, this is the audio review for Health Inequities, Social Determinants, and Intersectionality by Nancy Lopez and Vivian Gadsden from Race, Class, Gender, 10th edition. So problems in health disrupt the human development process. Despite some recent improvements, we continue to see significant disparities in the quality of life and health of minority children from low-income neighborhoods. So the authors argue that there's a potential for intersectionality to be a lens to study the social determinants of health, with the goal to reduce health disparities and promote health equity and social justice. So they argue that this potential power of intersectionality is to become a transformational paradigm. They argue for critical knowledge projects that question assumptions and meanings and the relationships between different social categories and intersecting systems of privilege and oppression. So they argue this approach pushes back against victim blaming. Further, they say by focusing on power relations at the individual, institutional, and global level, there can be a union of people's experiences within the context of history and society. Health disparities are part of a complex web of issues associated with inequality and inequity in other social institutions like education, housing, employment. So health disparities affect children before they're even born through maternal stress and other health concerns, and they affect children after they're born in a myriad of ways. So some structural barriers limit employment, housing, or cause housing instability that can contribute to homelessness, and there's so many other issues that make it difficult for parents to navigate, which then affects their health and their children's health. So the researchers draw upon Jones's definition of health equity and Collins and Bilge's definition of intersectionality to ground their research. They define an intersectionality health equity lens as ongoing critical knowledge projects, inquiry, and practice that are focused on how systems of inequality interlock to create conditions that offer health equity or health inequity. Potential applications of this intersectional health equity lens can challenge previous understandings and research approaches and help guide solutions. Okay, so developing this lens requires deep self-reflection or reflexivity on how different systems of oppression interact. The result produces different lived experiences, as lived experience can either enhance or challenge the developmental pathways of children through adulthood. The inequities affect parents and families and their abilities to ensure positive trajectories for their children. So the researchers also discussed the lens as praxis, or not only in theory, but in action of healthcare practitioners, researchers, and educators. Again, it's critical to self-reflect. As we examine our identities and our experiences with health and with inequality or oppression, we use our sociological imaginations to wed our individual experiences with the larger social context and historical context as parts of those interlocking systems of oppression and privilege. So the authors point out that the damage that's caused not just by these existing inequities, but also the subtle forms of inequity and discrimination that illuminate how problematic these issues are and how often they're rooted in the accepted social practices of medicine or healthcare, which is what makes them so hard to see. So they also talk about mapping the margins, a term they borrow from Crenshaw that means there's a need to see what's otherwise invisible. For instance, our social assumptions frame everything. So Crenshaw points out that the Black experience is seen as a male experience, and the female experience is assumed white. So where does this leave a woman of color? We need to map the margins to fully understand the culture that we live in, especially when it comes to health outcomes. So there's also other axes of stratification that get less attention than race, class, and gender, such as language in a nativist way, right? Demanding an immigrant learn English, or only providing materials in a healthcare setting in English, or only providing care in English. And so this marginalizes those who don't speak English or may affect those for whom English is not their first language. So creating intersectionality-grounded projects that integrate the issues of race, class, gender, disability, sexuality, and other identities, statuses, and social locations in research on health and well-being for a range of issues facing marginalized children, youth, and families. Obviously, this won't be easy, right? It will take work, self-reflection, and really continually need to do that reflective work to continue to map the margins as they emerge. So the lens helps us understand that every person's experience is fundamentally different than the experiences of others based on their unique identity and structural positions within systems of inequality and those structural barriers that they may face or may not face. Okay, so when it comes to integrating race, class, gender, sexuality as lived experiences, to create intersectionality-grounded projects, we must be aware of the overwhelming inequities that exist today as a result of long-standing problems of race, gender, sexuality, poverty, and others that form today's realities. So they draw upon Lopez's concept of lived race gender and racialized gendered pathways of embodiment as a basis for their application to health, what they then term racialized gendered social determinants of health. Also for their analysis, they cite W.E.B. Du Bois' concept of double consciousness, which is a concept that explores how people internalize the messages of society that demonize them, creating a double consciousness, which is an important concept within critical race theory, and really in examinations of gender, sexuality, colonialism, xenophobia as well. So a substantial barrier to changing health inequality and inequity is the dominance of hegemonic social identities as the basis of educational and health frameworks, which ignores marginalized communities' needs and perspectives and ignores important intersections that shape individual experiences of education and healthcare. A critical self-reflexive intersectionality health equity lens and praxis depend on a visceral commitment to uncovering the workings of multiple systems of inequality in the process of unpacking the social determinants of health. This could be expanded into an intersectional equity lens that centers the lives of groups that remain invisible. This requires a commitment to enlarging and diversifying the pool of health researchers. In developing their focus on intersectionality and social determinants of health, they attach analysis to the goals of advancing social justice.